Good afternoon, and thank you so much for joining us to Beyond Compassion, integrating financial health into patient care. I'm Adrienne White-Faines, and I am thrilled to have two wonderful panelists join me for what I hope is, and actually I know will be, a courageous and I hope often disruptive conversation. So, as everyone knows who has joined this call, the vast majority of people joining this conference here at CARE as One are actually in the healthcare field on the delivery side in most cases. And over the past 2 decades in the US, we've been on a stage of constant evolution as we've worked to increase access and address cost of care and adapt payment reform and seek more effective outcomes for patients all across the country, recognizing that we need to integrate social determinants of health in order to reduce disparities. But some social determinants of health are actually slightly more or easier to address than others, like transportation or food insecurities, even to some degree housing, seem tangible, understandable, and with structures you can actually begin to hit at some of those issues. But what seems more elusive has been the issues of addressing financial health, financial vulnerabilities, and their impact on healthcare, as well as we've seen and learned over the past 9 months, racism and other economic factors. So what we hope to do today is bring together two outstanding professionals who are passionate about their work and understand deeply the intersections between financial health, healthcare, and equity and outcomes, and see if we can all grow together to learn and be thinking about designing new solutions to try to improve both. So if you will, help me today to join in this conversation, Dr. Cheryl Rucker-Whitaker and Jennifer Tescher. I want to begin this conversation by first of all asking Cheryl, can you help me as the chairman and founder of Next Level Health Partnerships, which is a Medicaid managed care corporation, and president of the Institute of Medicine of Chicago, and as a physician fully committed to serving vulnerable populations and addressing disparities throughout your career. Can you share with me how you define health equity and some of the issues that you see as we try to achieve optimum health?
Well, thank you, Adrienne, for having me today. This is really, honestly, an exciting topic, and really the first time I've ever been on a panel with folks in the finance space. And really, really we're ahead of our times in a lot of ways in thinking about this. I've been on the front line of healthcare for, 20 plus years as a physician, and more recently as a founder of a Medicaid managed care health plan. And at that time, when we took that project on to sort of build a health plan from the ground up, we were trying to understand how our state spent over $15 billion a year in Medicaid services, but the disparities in healthcare in many of the communities impacted by poverty and who are Medicaid recipients was nearly intractable. And so as we began to kind of dig deeper over the years, health equity really took on kind of a new, there's a new paradigm that I'm playing with, which I don't think is rocket science, but it's the first time really that we're beginning to put health in terms of wealth. When the financial crisis hit in 2008, over half the wealth for Black families was wiped out. And so what you had as a result, sort of building on that, was really communities in crisis because, accessing some of the things that they might normally access became in turmoil. People's housing became a little unstable, et cetera. They may have, jobs, et cetera. Things were moving around that impacts your health over time. The stress there's a cycle of stress. And there's been a lot of good data to show that stress can impact ultimately your health. But what does health equity mean? what are some of the things that really determine whether a person has an equal opportunity to get to a healthy lifestyle, which leads to generally healthy outcomes? One, the ability to access a pleasant built environment that provides an equitable chance for things as simple as fresh air and a sidewalk to walk on, a stable work environment, um, a stable income stream, a safe built environment. So not just, a house and a car or an apartment, but a one where they feel safe. Mental and psychosocial supports. This is really important. There's a lot of data that shows that, if you have at least 3 to 4 people in your life that give more than they take from you, you're more likely to have a mentally stable, emotionally stable existence on the day-to-day basis. If you're always giving because the people around you are stressed in some kind of way, that means that you're going to be stressed ultimately. So having a supportive environment, and then also, then very last thing I'm going to say is access to that primary care doctor and access to health insurance that allows you to access the necessary type of healthcare providers. So I said all that, feels like it's long-winded. When I was younger, it was just having a PCP and health insurance. But now, as you sort of dig deeper, you find out that so many of these other factors weigh into health equity. Everyone's thinking, whoa, there's data that shows that your zip code really determines your healthcare. Well, we knew that 20 years ago, but now more than ever, we see the impact of wealth equity on health equity. Thank you.
Thanks so much, Cheryl. So, Jennifer, Cheryl was right when she started out and she said it was her first time really being on a panel with somebody in the financial institution. You, as president and CEO of Financial Health Network, have really brought voice and life to the issues of understanding financial vulnerability and financial health within populations. Before we go into the intersections of health and financial health, can you just begin by giving us some information about how you define financial health and how we in healthcare need to understand what that looks like and some of the issues around financial equity?
Absolutely. Good afternoon, everyone. Thanks so much for having me on. It's really lovely to share the virtual stage with you, Adrienne, and of course with you, Dr. Whitaker. I have seen for years now an analogy between what's going on in public health and healthcare and what's going on in financial services. And while there's some very significant differences between these two sectors, I actually think there are a lot of things in common. And I actually think that the healthcare arena is ahead of where the financial services arena is on these topics. And so I'm really excited both to share what we've been preaching, but also to learn from all of you. So when we think about financial health, what we're talking about is when people have the ability, they have a day-to-day system to manage their financial life in a way that helps them to weather financial shocks and to create long-term opportunity for themselves. So essentially, it's about having the systems and products and services and access that you need to manage the downside and to take advantage of the upside. When I talk about a day-to-day financial system, I think it's really important to point out that there are two elements. One are what I call the hard things, the structures, the institutions, the laws and regulations, the products and services. And then there's the soft things. Those are the decisions and choices that people make every day. And a functioning day-to-day system has to have both of those things. How many people do you know who who have all the access that they need to all the fabulous financial institutions and products and services, but make really poor financial decisions? And vice versa, people who are doing everything right but can't catch a break, or who face discrimination in the marketplace, or who, for one reason or another, can't gain the kind of access that they deserve. So having a day-to-day system is really about being able to make good decisions and choices in the context of having access and availability. We actually measure financial health. We've developed over the last several years a measurement framework and methodology, essentially based on 8 questions. And those 8 questions are in 4 categories: spend, save, borrow, and plan. They're things all of us have to do all the time. And based on the answers to those questions, you can give you a score on a scale of 0 to 100. And that then tells us whether you are healthy, coping, or vulnerable. If you're healthy, you're doing well on those 8 questions. If you're vulnerable, you're doing poorly on all 8 questions. And if you're coping, you've got a mix. You're doing okay in some areas and not so great in others. When we look at that data, very similar to health equity, we find all kinds of inequities based on whether it's race, gender, income, identity, ability. And so for us, when we think about financial health equity, it's about everyone having the opportunity to be financially healthy, regardless of those socioeconomic indicators. As an example, we do an annual survey called the U.S. Financial Health Pulse, where we essentially take a pulse of financial health in this country. And the most recent data shows that while about 1/3 of Americans are financially healthy, if you break that down by race, for example, about 39% of whites are financially healthy, and only 14% of Black people are financially healthy. So those are the kind of inequities that we can see from our data. Similar with income, there are plenty of people who make a lot of money who have poor financial health. There are people who don't make a lot of money and who are financially healthy. But in general, the less income you have, the less financially healthy you are.
Let's take that a step further so that everybody can get a good appreciation for how the population is faring. I think we have a slide that shows one of the most recent surveys done by Financial Health Network. If we can pull that up to look at the breakdown of financial health. So Jennifer, given this slide, can you talk to me about the observations that you have about the large percentage of people in this country then that are actually either financially vulnerable or financially coping? But
yes.
Also, what are some of the things that drive one from being financially healthy to financially coping or financially vulnerable?
Absolutely. So I said that we measure financial health based on 8 questions. As you might imagine, there are numerous factors, but we've been able to boil it down to these 8. And they are things like, in the spending category, it's I have more money coming in than going out, meaning I make more than I spend, and I pay my bills on time and in full. For the saving, it's about having adequate short-term savings and having adequate long-term savings. For borrowing, it's about having a good credit score and having a reasonable debt level. And for planning, it's about demonstrating a planning behavior, a future orientation, if you will, and having adequate insurance of all kinds, not just health insurance. And so you can extrapolate from that and imagine that if I am a family working a job that isn't paying a living wage, I'm going to have trouble right off the bat. If I have a health challenge, that may create real hardship for me, either because I don't have insurance at all, or maybe I have insurance, but I still have large debts to pay. That could increase my debt load. or it could mean I'm spending more on healthcare and that's challenging my cash flow. I could go through all of the social determinants that you talked about at the beginning and explain how they might have an impact, how they might ultimately impact someone's financial health. And I think for me, if there's anything that COVID has reinforced for me, it's that everything is interconnected. We tend to engage with people either as patients or as workers or as customers or as students, but that person is that they're all the same people. And if we're really going to make progress on financial health, but also on physical and mental health, we really have to pull those strands together, because as individuals, that's what we're all managing against every day. And frankly, some of us have a stronger system to be able to manage that than others.
Well, building on that interconnectivity, that clear interconnectivity, we know from Jennifer's comments that financial health is disrupted oftentimes by a health incident, particularly if you are vulnerable in the beginning. But we also know, Dr. Whitaker, that those with poor financial health tend to have poor health outcomes. Can you share with us and maybe give us examples of how this all comes together in an exam room or at the doorstep of healthcare facilities?
Well, let me talk about a few examples, and I'm gonna have you pop up a slide that I have to share with the listeners. There's a couple of things. So when you talk about low birth weight and maternal outcomes, while many African American women are impacted, there's certainly a disproportionate number of women who are, less sort of financially stable, who end up having low birth weight and troublesome outcomes for their infant. And that is, built in. The neighborhoods they live in are often can be high stressed. They can have, a fear of violence, activity around crime, or over policing or harsh laws in place that create like a high stress environment. Other things to think about are when environments are challenged, right, which is directly impacted to how much money you make. Where you live is really impacted by that number. The lack of safety or well-resourced built environment, place where you can walk around, go get a walk, get some exercise. We know that for type 2 diabetes, that being able to walk 30 to 45 minutes a day, 5 days a week, can actually, for some people, reverse the progression of that disease. That is real, and there's great data on that. So that's another condition where you live, which is directly impacted by how much money you make or your financial security, impacts kind of that condition. Another example, in environments that are less resourced, right? So you're living in this place because this is an apartment you can afford. The access to food is often high fat, high salt. Fast food choices. I actually live in a resource challenged neighborhood. By kind of metrics in many ways. And it's, I have to run to Hyde Park to get a salad. I can't find one in my neighborhood. So this means that, for people who are living with a condition like high blood pressure, if you're trying to get a quick bite, it's loaded with salt. And then over time, if you make that same choice over and over again, it's going to create an environment where that high blood pressure can lead to congestive heart failure over time, which can also lead to kind of kidney disease in being engaged. So those are a few examples. But I want to kind of take data that I know Jennifer looks at and kind of talk a little bit about some of the disparities in health that we see. So if you look at the chart on the far right, the deepest color of orange is low income neighborhoods. This is in like the Cook County, Chicago area. So look at the darkest on your far right, the orange. And if you track years of potential life lost, if you track homicide by community area, look at the dark blue. And if you track infant deaths, that's the dark red. You'll see that there's a lot of overlay with the neighborhood's income level. So this idea of financial wealth, and also, Jennifer, I love your terms about whether you're coping or those are very kind of interesting and new to me. So I'm feeling really educated by those, that you see that overlays with income. So these health disparities are overlaying very strongly with income. And, as some of the work we're doing right now, we've got about 1,500 high-risk Medicaid members that we are managing. And we spend our weekly case rounds, guys, solving social determinants. So we're not solving, they can often get to a doctor and get their medicines with some help from us, but solving those social determinants of health, whether it be issues around housing, issues around transportation, issues around whether they can pay their light or gas bill. Those are real issues that we spend many, many minutes talking about every week.
That's really helpful. Jennifer, let's jump in for some comment here. Chicago's a really good example. How have we, or how has Financial Health Network looked at infrastructure and how you can begin to focus in on those communities that the median income is so low? What are your suggestions especially for the healthcare providers on the call, as they're trying to say, what do you want me to do about it? What do we know about what can be done to help communities enhance that median income?
Yeah. So before I address that, let me just share a couple more data points that talk about this intersection between physical and financial health. In the survey that I talked about a few minutes ago, we also ask some very basic health-related questions so that we can get at it. And I want to go back to what Dr. Whitaker said at the beginning about the role of stress. 43% report that their finances cause moderate to high stress. 58% believe that their financial stress affects their physical health. And 65% believe that financial stress impacts mental health. And just to be clear, this is a nationally representative sample of about 6,000 people. One time we were leading a focus group, and we were leading a focus group with a group of workers at a workplace. And one of the people we were talking to said, you want to help me reduce my stress, help me pay my bills on time. So there's a really important connection between the stress that is driving illness, in many cases chronic illness, and people's ability to manage their own financial lives. And then also, as you said, Adrian, the cost of healthcare itself often results in challenges. So 25% of consumers in our survey did not get healthcare because they couldn't afford it. 17% stopped taking medication or took less than directed because of the cost. And then finally, when we look at those financial health scores, whether you're healthy, coping, or vulnerable, there's a direct connection. For people whose physical health improved, they had a 1.8, almost 2-point difference increase in their financial health score, as opposed to if your physical health declined, you saw a little over a 3-point decline in your financial health score. Similarly, if you had a major medical expense, less surprising there, you're going to see a decline. So very significant differences. And I think that what Dr. Whitaker said is so important, that I think that what we like to say is that whether you realize it or not, you're in the financial health business. And that you may think that you're a healthcare provider or a public health official or an insurance company or a health technology company, but if you're not thinking about and helping to manage the financial health of the patient, of the end user, you're not going to be successful ultimately in helping them improve their own health outcomes. And I think that the work, the casework in particular, for those with very low incomes is just absolutely critical. That plus making connections with community partners and resources, I think is just critical. There's very little substitute for some of that one-on-one work that needs to happen.
So, Adrian, let me just say something that, Jennifer, you brought up, in the exam room, what could doctors do? What could we do? Right. And I remember as a young physician, I would prescribe what the sort of recommended medicine was for that clinical pathway and trying to do evidence-based, medicine, everything. Person would come back in, 6 weeks or, whatever for a check. And I'd be like, oh, how'd it go? Da, da, da. And I was like, oh, they're like, well, no, I couldn't afford what you prescribed. And so, those are some of as we think about this financial health piece and trying to get people to physical health, because as healthcare professionals, many of us, we're trying to solve for that high blood pressure, right? We're trying to solve. But again, if you don't think about what that person's dealing with the minute they walk out the door, a lot of times the effort that you've expended, you won't get there. So I became much more aware of, hey, strategies for generics, which now many health plans push you to prescribe anyways. But you got to really be thoughtful when you're prescribing a high cost medicine. Hey, what are the programs that GoodRx and others that help people get these medicines at a lower cost? But I do think, to your point, like what can we do is a good question. Are there, should we, like you said, connect to community resources that might be offering classes on, hey, here's how you manage on a tight budget, right? And really sort of making that a place where people feel safe acknowledging that they're managing on a tight budget. And say, hey, we got 3 resources here. They take walk-ins and you can drop by anytime, or you can actually log on. Now, there are a lot of services that are doing virtual types of training. I would love to have a resource, book or so where I have those resources, Jennifer. If you had those, I think that'd be helpful to practitioners like nurses and NPs who are doing that kind of work. I don't know if that exists, but I think that could be kind of helpful for a lot of docs who are really trying to think about this social determinant thing. Like we're all kind of overwhelmed, right? Like you said, you had COVID in the mix, and the number of people who are living on the edge is definitely increasing. We probably don't know the extent of it all yet.
So this isn't a commercial, but just one example. There's a company actually based in Chicago, although they operate nationally, called Spring 4. Adrian thought I was going to say something different. You thought I was going to talk about NowPow, which you should talk about. But I'll give the example in the financial services world. Think about it from the perspective of a bank that has a loan to somebody and it's COVID and people are really challenged and struggling. What can that lender do to offer a broader array of services that might help that person in their financial life so that they can keep paying on the loan? Spring 4 essentially does that. They partner with lenders, banks of all kinds, other financial services companies, and it is essentially like a national resource bank by community for a range of issues. I don't see any reason why healthcare providers couldn't access the exact same kind of service, right? Because it's an extension of what are the other things going on in someone's life and what are the resources that might be available to them elsewhere. Adrian, you might want to talk about NowPow, which is specific, I think, to healthcare. I think is a similar idea.
Yeah, we use NowPow. So Adrian, go ahead.
Whether it's NowPow and Bertha's, et cetera, I think the key is from a technology standpoint, trying to work to make sure that clinicians especially, get more information about how to assess and understand their patient's financial health, because income is not your basis. Just because someone's getting a certain income does not mean that they have financial health. And the second is, once you know that a patient has vulnerabilities, what resources can you provide for that patient to help not only their financial health to reduce stressors and improve their health, but also enhance their ability to comply with the care that they need. So NowPow and Bertha's, others, even Innovator has platforms to help connect people to take resources and bring it forward to the clinician. But the key is trying to get the information at the right time to individuals who can help the patient at that moment. Cheryl, do you want to add how that's useful or what you've done with Next Level?
Yeah, we were actually the first health plan to partner with NowPout in the city of Chicago, and so now that we're really digging deeper, if you will, into the care management space, and we're seeing a lot of folks with numerous complex illnesses that if we don't manage them, the outcomes are not going to be good. They're all struggling with social determinants, and so we found that tool to be very helpful. We've also, though, found other resources that, we're going to support that company to, hey, we've got some information for you here because our folks are really on the ground and they're from the communities. I think it's also important, guys, to really think about how we build capacity in communities so that themselves, they can be a part of their own solutions. And so that's, the folks we're hiring, many of them live in the same communities. They have, maybe similar, experiences for our members. I think that's also important. So I think one of the things I want to do is for my care management curriculum, my learning curriculum for my care managers, I would like them to go through this type of training so that they're sensitive to it, not only sensitive, but also understand what other types of resources might be out there to help people. I do think, Jennifer, to something else you were saying, there's probably a large opportunity to really increase people's own capacity to manage their dollars. Because one of the things you said you can have income, but you still may be fragile financially because you're not managing those dollars. And I think, to be realistic, the times that we live in now, well, life's a little more complicated. I think the work environment's complicated. I think it's challenging sometimes to manage your finances. I mean, some of us may take it for granted, but it may be very challenging for someone to manage their inflow and their outflow if so many things are going on at one time. And, if you look at right now as an example, if parents are handling their children remotely, they got to make sure they eat, and they are working remotely. When are you going to really have time to sort of manage your in and outflow, right? So it can be very stressful. And I think that just attention to it, and acknowledging it sometimes is a very good thing for people and patients. Just acknowledge that, and that will give people, wow, this person is empathing with me. But I think also just having a line of sight on the resources is very helpful. And training some of our staff, not doctors, because in the chat, I see that folks are like, well, docs are pretty busy. We can't take on another thing. I 100% agree with that. But then that front line, perhaps we're training some of our medical assistants. We're training our care managers if we're doing delegate case management to be aware of these issues and the resources that are available.
Adrian, I want to say one thing, but this might actually take us nicely into, I think, the next topic we wanted to talk about around technology.
Go ahead.
So one thing I just think it's important to say is that people who have the least money are the best managers of that money, right? They can make a dollar stretch more than people who have an abundance of money. And so in general, while I think it's important that we all learn to be good consumers, whether that's of financial products and services or healthcare or the toaster oven we're going to buy tomorrow. And while I do think there are some basic things we should all know about how money works, I generally think that financial education per se is not the biggest problem that people have. It's all the other things we talked about. It's time, it's stress, it's frankly not having enough money, or it's having very challenged cash flow. We've done a lot of research that helped identify this issue of the mismatch between the timing of when people's money comes in and how much is coming in, that people have extremely volatile incomes, far more than we realize, and at relatively high income levels even. So how much they're getting every 2 weeks or every month varies in a way that is often unpredictable. And then the timing of when that comes in versus when people's expenses hit is often a mismatch. That in and of itself, forget about everything else, that in and of itself is a huge issue around people being able to sort of manage, particularly when there's no cushion. If you had a big savings account, so what? But most people, as we know, 40% of people in this country couldn't come up with $400 without selling something, borrowing something, et cetera. So I think that's a really big part of the challenge. I think this is where technology can be extremely helpful. I don't think technology is the solution to all problems in financial services or in healthcare. But I do think that if we're trying to give people back some time and try to simplify things for them, technology is extremely helpful that way. So we spend a lot of our time investing in early stage fintech companies that are solving some of these core financial health challenges. And we've invested almost $10 million over the last 6 or 7 years. We've invested in about 40 companies. And they're doing everything from helping people to set aside small amounts of savings, to help people understand what's going on with their money and automate certain things to make it simpler and faster. And I have long thought that there's a really interesting connection between the kinds of financial tools that have been developed and some of the really interesting electronic health tools. A lot of them are all about behavior, right? Taking your medicine, gamifying certain behaviors. And there's a lot of similarities with what's going on in financial services. And so one of the things I've always been interested in is trying to understand some of those intersections and see whether there's an opportunity to put some of that functionality together in a useful way.
We are running close on time, and I have so many questions that I want to ask of both of you. But as I look at the Q&A that have been popping up on the chat, one of the questions, and I think, Jennifer, I'm going to send this to you, is someone is asking if there are any provider-payer collaborations about improving care from a financial perspective. And I think maybe one of the examples that we can address is really how is the financial environment working with healthcare providers or employers and payers to deal with medical debt. I know that the Financial Solutions Lab has actually invested in some products and entities that are looking at medical debt. Do you have some thoughts on that?
We had one investment in a company whose business model was essentially to help customers, patients, negotiate their insurance claims, because often the amount the insurance company originally says that you're going to owe is not what it really will be. And that can be a very confusing process. And as you might imagine, that didn't go over very well. And that company had to pivot and is doing something else. I think medical debt is a huge issue, and it's not just an issue for people who don't have insurance. It's a huge issue for people who do have insurance. Mm-hmm. And I think that too often we gravitate towards credit. As providers and payers, we gravitate too much in offering credit as the solution to the problem. And I think that on the financial services side, I think there's some work that's been done in terms of how to, when lenders or other companies are underwriting consumers, making a decision about whether they're going to do business with them, they've gotten smarter about how to look at credit data so that people aren't being disproportionately impacted by healthcare debt, because I think most people understand that that's often out of their control. Mm-hmm. Something happens, they have a big health bill, and that's not necessarily predictive of their ability and willingness to pay some other kind of loan. So I think there's much more work to be done in that arena.
Let me jump to you, Dr. Whitaker. We've just been through a pandemic that brought forward all kinds of awareness about vulnerable populations. But it also, over the last 9 months, we've opened up visibility to another longstanding issue, which was around systemic racism. Do you believe that there is movement or action, or what learning do you believe is essential coming out of this about what some of the payers and providers need to be doing to really address, from a population health status, some of these social determinants of health?
So that's a
Loaded.
that's a great question. Yeah, that is a lot. That's a lot. But I think it's a great question, and one that, if you ask me next week, my answer may change, right? Because I think this is an evolving time in the history of our country, but also in the history of our thinking as healthcare professionals for us. There's a couple of things. I mean, there's multiple layers of kind of policies and practices that have led us to some of what we're seeing as outcomes in the healthcare space. I want to start with something as simple as training on implicit bias training. There's legislation before the Illinois legislature that it will require implicit bias training for all healthcare professionals. Now, will that solve everything? No, but it should create a thinking environment that allows you to sort of understand when you might be applying biases to the care or treatment of an individual. The other time is to look at kind of where we're investing public dollars when it comes to healthcare. Are we funding the same system that is giving us the outcomes that we're getting? Where could we move dollars to that would ignite some of this thinking around creative solutions and practice opportunities when it comes to social determinants of health, which are driven by wealth disparities. And then, so that's a big one. I'll give you an example. For the CARES Act, as a result of COVID-19, over 600 or so million was given out by sort of around for healthcare in Illinois. Where did those dollars go? Did they go to innovative things that would be changing kind of the game, or did it go to the same people who always get the money? Because if we funded the same people, we're going to get the exact same solutions that we've always gotten. And then my third one is, because we're coming up on time, I know, but there have been several of the large foundations that have put out really high dollar challenges, guys, to come at racial equity from various lenses that I'm very excited about. The Kellogg Foundation put out one. There's a $90 million, it's being managed through the Lever Fund, I believe. But folks are putting in big dollars. They're looking for big ideas that, RFP, I think it's due next year, and then money will roll out in 2022. But very exciting, $10 and $20 million grants to say, hey, give us some bold ideas. So I love what I'm seeing in terms of philanthropy really kind of driving investment in new direction.
And because we're up on time, Jennifer, let me give you the last word. So where do you see the hope, and where do you think are the essential challenges that need to occur?
I think one thing we haven't talked about that I think is a really important piece to all of this are the role of employers. We already know that employers represent distribution for a significant portion of patients out there from a health insurance perspective. And employers are also like the place you get paid, the place you potentially save for retirement, the place you get a whole bunch of other voluntary benefits. And so we're increasingly doing a lot of work with employers around their role in the financial health of their employees. I often say that if you're an employer and you're doing things to help reduce your healthcare costs for really big companies, and you're not thinking about the financial health of those employees, you're just bailing a leaky boat because, again, of that connection to stress that we talked about earlier. And so I know there are a lot of people who are outside of the mainstream workforce who often have very significant chronic disease management challenges. but I do think the role of employers shouldn't be understated with at least some portion of the population. And it just so happens that in this racial reckoning that we're having, large companies are more broadly thinking a lot about equity issues writ large. So I think there's an interesting intersection there.
Well, thank you so much. And there are so many questions we did not get to. This is clearly a conversation that needs to continue. I want to thank my panelists and all those that attended for the CARES One Summit.
Thank you.
Thanks, everybody.